Hello and welcome back to this week's ECG of the Week. Take a second here to pause the video and remind yourself of this week's clinical vignette. Now let's take a look at his ECG. So we're going to use the 6-step method that we outlined in our ECG Basics video that you can find on our YouTube channel as well as our Facebook page. The first step here is to find the rate. So we'll have a quick glance and see if we're working with a regular or irregular rhythm to see which method to use. And if we zoom in here, we can see that the distances between these R peaks seem to be a little bit irregular. So we'll use the 10-second method. This involves counting all of the R peaks all the way across this ECG strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, and 23. So 23 times 6 is about 138 beats per minute. So that's just a helpful little tool. If the beat is irregular, you can use this 10-second method to find the rate. Next, we're going to take a look at the rhythm. So we started off, we said that the rhythm looked a bit irregular. We'll go a little bit further now. So is it regularly irregular? So are there any patterns that we can see? Or is this irregularly irregular? And if we take a close look here at lead 2, we don't really seem to see any sort of pattern here. So we would say call this irregularly irregular. Next step is looking for a P wave. So if we zoom in here, so you'd expect a P wave to be before our QRS complex. And we do see some of these squiggles here, but there's not the same morphology across the whole ECG strip as we would expect with a P wave. You would see the same thing across the same lead. So across this whole lead 2, you'd see the same P wave morphology, but it doesn't seem to be there. So we'll say that the P waves are absent. The QRS complex, so we're looking to see if this is narrow or wide. So this looks to be about 1, maybe 2, possibly 2.5 small boxes. And if you remember, the small boxes correspond to 0.04 seconds or 40 milliseconds. So this is less than 120 milliseconds, which is a normal QRS complex. Next is the PR interval. Since there's no P wave, there is no PR interval. And then finally, we're going to look at the ST segment. So essentially what we're looking for is any elevation or depression after the QRS complex. So at the J point, we'll zoom in here. We see that we can approximate the isoelectric line to be about right here, going all the way across. We see that at the end of these QRS complexes, it does return to the isoelectric line at the J point. So this would be normal. There's no elevation or depression. So next slide here, just our findings. The rate was 138 beats per minute using the 10-second method. The rhythm was irregularly irregular. P waves were absent. The QRS complexes were narrow. There is no PR interval, and the ST segment was normal. One other thing here, it's pretty subtle in this tracing, but you can kind of see a loss of an isoelectric line or a wandering isoelectric line. And you can kind of see this moving up and down a little bit. It is more pronounced in other ECG tracings that you would find for atrial fibrillation. So this is really pathognomonic of not having a P wave. And an irregularly irregular rhythm. So let's talk a little bit now about the pathophysiology of what's actually going on inside the heart. So in a normal sinus rhythm, you'll have a single electrical signal that originates in the SA node and then transmits down to the AV node. This will have the right and the left atria contract together in a coordinated manner and then pass on to the ventricles. However, in atrial fibrillation, there are multiple electrical signals that originate in different locations other than the SA node. So these are ectopic signals. And the right and the left atria will actually contract chaotically, so not together, not coordinated. And this actually leads to the atrial fibrillation that we see. If we go back here, we can zoom in, we can see that these little squiggles here are actually the atria fibrillating or contracting chaotically. So what's the mechanism behind this? So there's an initiating trigger as well as an underlying substrate. So some of the triggers that could initiate AFib would be premature atrial contractions, a focal atrial tachycardia, so a fast atrial heartbeat, or atrial flutter. So there's a focus that is present in the atria or the proximal portion of the pulmonary veins, or we can have focus or foci that have reentrant pathways. So this is where an electrical signal will kind of loop back and just propagate continuously. And then you also need a substrate. So these are the underlying factors that promote the perpetuation of AFib. And these can either be structural or electrical. Some examples of that would be atrial hypertrophy, dilatation, or fibrosis for structural. And then electrical, you can have changes in ion channel functions or changes in calcium homeostasis as well. There are a few different risk factors. Some big ones here are age and heart disease, obviously. High blood pressure, other chronic diseases. Sleep apnea is very common. Alcohol, you'll see very often. And then also family history and obesity. There are a lot of risk factors for this disease. And it is actually the most common arrhythmia that's seen. So you are more than likely to see this on the wards when you're in the hospitals. So just some interpretation tips. Like I said before, the rate or the rhythm will be irregularly irregular. So you'll have this fluctuating RR interval. So if we zoom in here, we can kind of see what that looks like. There's 21 boxes here, 15 small boxes here, 11, 17. So the distance between these peaks is not, there's no pattern, there's no repeating pattern. So it's not, it's irregular, but it's also irregularly irregular. So determining the rate, you'll use the whole rhythm strip, the 10-second method. There are no P waves present. So if we go back here, these are fibrillatory waves. They're not P waves. So this is actually just the atria contracting chaotically multiple different times and fibrillating. There's an absence of an isoelectric baseline. So on the previous slide, I was kind of just cheating a little bit by drawing an isoelectric line. You can sort of gauge where it might be, but as I said, you're going to have this wandering isoelectric line that may be more pronounced, it may be less pronounced, as was in our tracing this time. You can either find fibrillatory waves that are fine or coarse, and these may mimic P waves, so you really have to be careful to not call these fibrillatory waves P waves. And then finally, the QRS complexes are usually less than 120 milliseconds, so this is a normal narrow QRS complex. However, if you have something like a pre-existing bundle branch block, an accessory pathway, or some sort of rate-related aberrant conduction, these QRS complexes could be a bit wider. So here's an example of atrial fibrillation. If we zoom in here, you can see that there is sort of an irregular ventricular response. So these QRS complexes are a bit wider, as you can see here. But we also don't see any P waves here as well. And we can see the fibrillatory waves, if we zoom in really far, we can see they're very fine. It almost looks like a straight line here because of the resolution, but the fibrillatory lines are very, very fine. If we zoom up here to V1, it might be the best view. Very fine fibrillatory waves. So in our next example here, we have atrial fibrillation with a slow ventricular response. So essentially what this is, you can either have a fast or a slow ventricular response. That's just essentially how fast the QRS complexes are coming in. So if we zoom in here, we can see that this is a very slow rate. 1, 2, 3, 4, 5, 6. So 6 times 6 is 36. So our rate here would be about 36 beats per minute. That's very, very slow. If we actually go up to V1, you can see fibrillatory waves up here as well. Kind of all the way across. We don't see any P waves again. So yes, this would be another example of atrial fibrillation. Just some final takeaways here. So this irregular rhythm is exclusive to atrial fibrillation. So if you do hear that, it pretty much gives it away. The ventricular rate can be fast or can be slow. The electrical conduction through the atria is chaotic and uncoordinated, so you'll have the absence of P waves, and you'll actually have these fibrillatory waves. But be sure not to confuse these for P waves. We want to make sure that this is very important to know. It can be kind of confusing. They may be around the same amplitude, but do not confuse these for P waves. So atrial fibrillation is the most common arrhythmia. It can manifest in numerous patient populations. As we mentioned before, there were a ton of different risk factors, from being structural, congenital abnormalities to lifestyle factors such as alcohol and smoking. So there are a lot of ways that someone can actually get atrial fibrillation. And actually in Ireland, 1 in 4 people over the age of 50 are at risk of developing AFib. So this is a really important rhythm or morphology to know for when you're out on the wards. So make sure you take a look at this video and just familiarize yourself with what to look for atrial fibrillation, and you'll be in good hands. Thanks for watching, and make sure to check in next semester for our next edition of ECG of the Week. Thanks.